A very good evening to everyone. The title of my paper is Submacular Hemorrhage Displacement using subretinal TPA and air versus subretinal balanced salt solution and air. So I have no conflicts of interest. As we know, submacular hemorrhage can occur secondary to wet ARMD, PCV, myopic CNV or a RAM, and the natural history of these hemorrhages is poor. So early displacement of hemorrhage from the macula is recommended to restore useful vision. And various techniques have been described in the literature, ranging from surgical evacuation to intravitreal gas and TPA to PPV with subretinal TPA. However, at present, there is no consensus or treatment guidelines regarding the optimal management. So, our study was done with an aim to study the role of subretinal BSS as a substitute to TPA in the management of large submacular bleeds. So, for the purpose of study, the fundus was divided into 4 zones. Zone 1 involving the fovea, 2 involving the macula, 3 reaching up to the equator, and 4 beyond the equator. So the primary objective was to see the displacement of the bleed from baseline at 1 month within each group and between the 2 groups. And the secondary objective was to see the change in BCVA from baseline within each group and between the 2 groups. So the outcome was assessed in terms of complete success, that is when the hemorrhage completely displaced from zone 1 as well as zone 2, partial success or failure. These were the inclusion criteria. Only large submacular bleeds with at least size of 4 disc diameters and less than 14 days duration were included in the study. So this was an ambispective, non-randomized interventional study, and the patients were divided into 2 groups. This is the procedure which was followed. Group A patients underwent PPV with induction of PVD, followed by injection of 0.3 to 0.4 ml of subretinal TPA and 0.2 ml of air, followed by partial FAX, 20% SF6 tamponade and heads-up positioning. And the entire procedure remained the same in Group B, except that instead of TPA, 0.3 to 0.4 ml of subretinal BSS was injected. So this is a short video showing the steps. These were the results. 10 eyes were included in the TPA group and 11 eyes were included in the BSS group. So as we can see, the most common cause of hemorrhage was PCV, followed by wet ARMD in both the groups, and the average size of hemorrhage was 6 disc diameters. So majority of the hemorrhages were involving zone 1, 2 and 3, that is at least reaching up to the equator in both the groups. So coming to our primary objective, 9 out of 10 eyes in the TPA group and 9 out of 11 eyes in the BSS group showed complete displacement of bleed both from zone 1 as well as zone 2. And coming to the secondary objective, there was significant improvement in visual acuity from baseline both at 1 month and 3 months in both the groups, and the gain in visual acuity was comparable when both the groups were compared. So coming to one of the case example, this was a case of a 65 years female with hemorrhage secondary to wet ARMD. We can see that the hemorrhage has displaced, however the visual acuity remained guarded due to a subfoveal scar. And coming to example of a patient in the BSS group, this was a 45 years male with hemorrhage secondary to retinal artery macronism. We can see that the hemorrhage is cleared and the visual acuity has improved from hand motion to 618. So to conclude, pars plana vitrectomy with injection of subretinal balanced salt solution and air followed by fluid air exchange and SF6 tamponade is effective in displacing large submacular bleeds within 2 weeks of symptom onset and is comparable to subretinal TPA. However, there are certain limitations. It's an ambispective non-randomized study with a small sample size, and toxicity of either BSS or TPA could not be assessed. So I would like to thank my mentors, Dr. Mohit, Dr. Diksha, Dr. Basav, and Dr. Ramandeep for helping me carrying out this study. Thank you.
Thank you, Dr. Sabia.
Thank you.
This was a wonderful presentation. But I wanted to ask you, did you look at the short-term IOP rise in these patients? Were there any suspects or were they prone for any glaucomatous changes?
Yes, ma'am. So,
And
variety of
any
factors.
developments of cataracts in phakic patients
Yes, ma'am.
compared to the TPA group? You're injecting BSS with
Yes,
air.
ma'am. This was a detailed thesis which was done. We also looked at the visual acuity as well as IOP as well as complications that had developed over the follow-up period. So the phakic patients did not end up developing cataracts. However, most of the patients were pseudo-phakic in our study, and there were no IOP rises. The IOP remained controlled in these patients.
What's the gauge of this needle that you used for
Ma'am,
subretinal?
this is 38 gauge needle.
And
38 gauge.
what's the site of injecting? Like,
Ma'am, so in our patients, we injected just below the superior arcade,
just means inner to the superior artery.
inner to the superior arcade.